And I'm really excited to talk to you today about cervical cancer elimination and what Canada and what the global community is trying to do to get there. And thanks for my introduction. I have the privilege, but also stark reality of being affiliated with many institutions, but that's how you work in partnership. And so I'm very glad to represent all of these institutions. These are my disclosures. So I speak and take funding only from not-for-profit and non-governmental organizations. Okay, so let's just set the context in the picture of cervical cancer and cervical cancer elimination. So globally, 1 woman every 2 minutes dies of cervical cancer. And while that's sort of horrific enough, there are some specific things that make this a really important problem. So first of all, this is a cancer that is almost entirely preventable through vaccination. So we have a way to prevent a cancer. Secondly, for women who have acquired HPV, and we can actually screen for that, and we can detect those precancerous lesions and prevent the development of cervical cancer. And third, when we find the cancer early, say stage 1, we are successfully able, with things like hysterectomy and radiotherapy, able to actually prevent further progression and actually treat and cure invasive cancer. So really, the elimination of invasive cancer is within reach for all countries. So this is not something like, precision medicine where we hear in, 5, 10, 20 years, we're going to be able to do this. We actually have all the tools to eliminate this cancer now. But what is the stark reality? Well, approximately 500,000, there are almost 600,000 cases of cervical cancer every year, and almost 300,000 deaths in 2018. So again, just keeping in mind, these are very preventable cancers. It's the 4th most common cancer in women. And the estimated age standardized incidence was about 13 per 100,000 women globally. And that varies. So in Canada, we're at about, our incidence is probably about 5 to 6 per 100,000. And other places where I work, like Uganda, we're over 75 per 100,000. So a real range. And there have been some important quotations, but really cervical cancer is almost the starkest marker for me of inequity and health inequity. So I always show, even though I'm talking to Canadians, I always show this graph and this map, because I think it's really important for folks to see where the burden of cervical cancer is distributed. So you can see in large part that the countries and regions that have the highest burden are sub-Saharan Africa, southern South America, and also South Asia and Southeast Asia. Many of the countries with green it's not that they have any lower HPV rates, but because they have screening programs, they're able to prevent the progression of HPV infection to precancerous lesions onto cancer. So you can see North America, Western Europe, Northern Africa, and Australia and parts of East Asia, including China, have lower rates of cervical cancer. So the WHO has named cervical cancer a condition of public health import, a disease of public health importance. And they have set the following targets and goals globally for us to achieve. So the first is, of course, prevention, and we do that, the primary prevention, we do that with the vaccine. So there's a goal to have about 90% of girls fully vaccinated with the HPV vaccine by 15 years of age. And just to, again, reiterate these goals, we're aiming for 2030 to have these goals. So every girl, 90% of them would be vaccinated by the age of 15. There's an aim to have 70% of women screened using what's called a high performance test. So that's a molecular test for HPV at twice in a lifetime, at 35 and then at 45. And then there's a goal to have 9% of women who are identified with cervical cancer to receive treatment. So those are the global goals. I'm going to drill down now to why these are important, and then why, and then what's happening in Canada. So this is a figure from some modeling done by colleagues both in Australia and in Quebec, Karen Cancel and Jane Kim, who's at Harvard, and then Marc Buisson, who's in Quebec. And what you can see here is this is about how do we get to those elimination goals? How do we get to elimination by the end of, say, this century? And you can see that we get there regardless of whether we focus only on vaccination or if we focus on vaccination and screening. But you can see that, and I'm going to show you in a little bit more detail later, but in between here and here, so if we look at this approach, which has both, which has only vaccination, so the blue line, and if we compare that to, say, the purple line, where we have vaccination but twice in a lifetime screening, the delta in between here are deaths. Okay, these are folks who have died, women who have died from this preventable cancer. So by deploying both a primary and secondary prevention approach, you actually reduce unnecessary deaths and substantial number of unnecessary deaths. So this is another way to show the WHO approach to cervical cancer control, where we have a focus on primary prevention to prevent acquisition of HPV. We have a focus on secondary prevention to offer improved detection and screening, and then tertiary prevention, which is treatment, but also recognizing the importance of dignity and humanity, also offering palliative care. And again, that's been sorely missing across the spectrum. So what's the story for Canada? Well, in Canada, the median diagnosis of cervical cancer is about 47 years of age. And 73% of women who have cervical cancer are between the ages of 25 and 59. So just want you to think about those women 25 to 59, how they are spending their lives, how they're spending their time. So usually these are folks who have not, they have their own work, their own sort of well-being, but they often have big caregiver responsibility for children, nieces, nephews, other people who are guardians for, Hello. Sorry, just a second, my phone is going off. They also then have a care responsibility for their parents, even for grandparents. And then they also have often roles in their community, leadership, roles in terms of income generation. So when you take those women out, there is a ripple effect of the impact of their loss. We also know that immigrant women, women who do not speak English or French at home, are more likely to develop cervical cancer. And we also know from data in BC that First Nations women are almost twice as likely to develop cervical cancer compared to non-First Nations women. So we have not only this significant burden of disease, but we have people who are often shoulder greater disease, are often lower income and also face greater concerns. So what is the Canadian strategy? Here are our targets. So overarching principles: we want culturally appropriate care that is closer to home. We want people-specific self-determined cancer care, and we want to respect and honor and support Indigenous governed research and data systems. So our vaccination goals are to have 90% of 17-year-olds fully vaccinated with the vaccine by 2025. So just a reminder, that's in 3 years. We want to implement primary HPV screening by 2030. You can see we have both the goal of 90%, but also 80% coverage. So equity-seeking groups also have access to this. And we want to have very good follow-up of abnormal screening results up to 90%. And how are we going to get there? Well, let's talk a little bit about the vaccine. You can see that the goals and the priorities include increasing the awareness and acceptability of the HPV vaccine, increasing vaccination uptake in the school-based programs, and improving ability to measure and report vaccination coverage rates from the school-based programs. For screening, as I mentioned, we're looking at 90% of eligible individuals being screened with an HPV test, and also making sure that in equity-seeking groups, we have at least an 80% coverage. So in order to get there, we need to look at implementing primary HPV screening across the country. We need to ensure there's good cervical screening participation. We want to look at self-collection to offer broader coverage, and we want to make sure we can report on aggregate data. So I want you to think back to that map I showed you, and then look at the HPV-funded programs. And I call this the shadow map, where we have the most established national programs in the countries that have the lowest rates of cervical cancer. And that's not to say we don't want those HPV vaccine programs in places like Canada. We absolutely do. But I think it also highlights the real urgent need to make sure there's improved coverage globally. So here's our Canadian data. You can see the uptake rates across the country here with the different regions. And you can see for Ontario, we're just over 60%. So big gaps in terms of coverage, both for female and male. Similarly, when we look at, when we have a deep dive into the decisions as to why parents are getting the vaccine for their children or not, you can see that there's some themes that emerge. So one of them is around effectiveness. One of them is their age. One of them is safety. A key issue is the information that they received. Some of it is about access and when it's available. So really important considerations as we try to improve the coverage of the vaccine. And if you look at particularly the group I'm particularly interested in is the children, and why I'm interested in that is we know that this is a preventive vaccine, so we want to get it into young people. We want to get into them earlier, and we want it to get into them prior to sexual debut. And you can see that data and concerns for parents remains around effective, safe, lack of awareness and information, and the children are too young. So part of what I hope to, as trusted healthcare professionals, pharmacists play a really important role in ensuring parents have the right information and choose to get their child vaccinated against HPV. So what we know from data is that that trusted practitioners are a great and one of the most important, probably the most important way to get good vaccine coverage. And we also know that by reducing doses, but talking and confirming safety and efficacy, that that can also be highly influential for parents. So here's the first thing I want to show you is some work that was done actually in British Columbia, Quebec, and in Nova Scotia, where we led the study to look at if we could reduce doses. Because as you know, parents are very susceptible to fewer doses. They want fewer doses of vaccines. So we looked at whether 3 doses and 2 doses were equivalent. And we did a non-inferiority study where we randomized girls to either 2 doses at 0, 6 or 3 doses at 0, 2, and 6. And just to be clear, the age groups of the girls was 9 to 12, but the comparison or the efficacy group was the group 16 to 26, which is in whom vaccine efficacy had been established. If you take a look to the right, the CLIA, the results for HPV 16 and 18. So this is looking at the geometric mean titers for the antibody thresholds, comparing for HPV 16 and for HPV 18. You can see that once you hit sort of 24 months after 2 doses or 3 doses, either in the girls or women, you can see there's a flat line. The plateau is flat. So what does that mean? That shows that the immunogenicity data shows that the vaccine is non-inferior, so 2 doses is non-inferior to 3 doses. So we can, and so you probably all know that for school-based programs, we now do 2 doses. So it was based on this data. So that's really important for parents because we can tell them many things, including we continue to evaluate, we monitor, and we try to give the least doses, fewest doses possible. Second concern of parents is that of the impact of this vaccine, because we know HPV is acquired sexually, parents are worried that by giving a vaccine for a sexually acquired infection, that parents may feel that it gives a message to their children that they can practice unsafe sex. So parents were very worried about that. So we use the BC Adolescent Health Survey, which is a provincial survey done every 5 years where every adolescent from grade 7 to grade 12 is asked to complete a health survey. And we looked at sexual health practices before and after the introduction of the HPV vaccine program. And we weighted the sample for adolescent girls and to see what the impact was on their sexual health choices. And this was published in the CMAJ. And you can see here that after the introduction of the HPV vaccine program, there was no negative impact on sexual health choices of young people. So that's the message you want to give to clients who come in and are asking about the HPV vaccine. We have good data that shows there was no change in their sexual health choices. You can see here the odds of being sexually active was actually lower after the vaccine. The rates of intercourse before the age of 14, use of substances, and pregnancy were all actually significantly lower after the introduction of the vaccine program. And youth actually reported higher rates of condom use and birth control pills, and also no change in the higher number of sexual partners. So reassuring for parents, no change in sexual health practices. In fact, slightly better sexual health practices after the introduction of the HPV vaccine. Another thing parents want to know, is the vaccine effective? So this was a vaccine effectiveness study we did in British Columbia, where we took the vaccine registry, looked at the cervical cancer screening registry, linked it, and looked at those who had been vaccinated and those who had not been vaccinated, looking at the rates of precancerous CIN2 lesions. And you can see that the rates of CIN2 were, their risk reduction was 0.42 for CIN2 in individuals who were vaccinated, females who were vaccinated, compared to those who were not. This is also an important thing, and we talked a bit about trying to get the vaccine earlier. Compared to 9 to 14-year-olds, if the vaccine was given over age 15, it was still effective. Okay, it was still effective. There was still a reduction. But compared to the 9 to 14-year-olds, those who got the vaccine after the age of 15 had a higher rate of precancerous lesions, were more likely to have precancerous lesions. So what does this say? We want to get the vaccine in earlier, so that grade 7 program, really important to get the vaccine in at that time. And this is a similar data showing population level, ecological data showing significant risk in population rates of CIN2 after the introduction of the HPV vaccine, showing we're seeing benefits. And these are BC data. There's similar data from across the world that shows this vaccine is safe, very effective, and optimally given at a younger age. Here's the exciting data from our colleagues in Europe and Scotland, who looked at rates of actually cervical cancer. So not just the precancerous lesions, but cervical cancer. And you can see here, as we track the rates of the cumulative rates incidence of cervical cancer per 100,000. You can see here's the rates in unvaccinated, and here's the rates in vaccinated at 17 to 30, and here's the rates in vaccinated under the age of 17. So just a staggering reduction in cancer. So again, back to our earlier discussion, we actually have tools to prevent cancer, and these are available now for young people to have them. But you saw the rates in Ontario, you saw the rates across the country, so significant gaps, significant work to do. So what do we need to do? We need to ensure that, and there are many folks who would like to see the vaccine available. It is publicly funded in most jurisdictions, but it's often publicly funded for under 17. Many folks wanting to see it more broadly covered. We want to improve accessibility, so particularly for those who did not take advantage of it in school-based programs, and really work on acceptability. And I talked about some of the key acceptability things, advice coming from a trusted health provider, confirmation about its safety, confirmation about its effectiveness, confirmation that it does not impact on sexual health choices of young people. And we're already seeing benefits against cancer. Okay, so now we're going to talk a bit about the screening for cervical cancer. So if you think back to that figure I showed you, remember I said if we only relied on vaccination, we'll get to those goals of elimination, but in the interim, there will be many unnecessary deaths that we can prevent. So what we want to do is actually improve our screening. And so this, I'm going to talk to you about why we're moving to primary HPV testing. So we're pleased in Canada, and I was able to lead one of the big trials globally that compared HPV testing versus cytology or pap smears. And this was the HPV FOCAL trial, where we randomized women to either an HPV test, so they would have their HPV test, and if they were negative, they came back in 4 years, to a cytology. So if they had cytology and they were negative, they came back in 2 years and then 2 years after, okay? So it was a screening trial where we compared that. The outcome was precancerous lesions at 48 months. So those precancerous lesions that can lead on to cancer. We also had outcomes of CIN3, the most severe precancerous lesion. We also looked at CIN2, and we looked at economic and colposcopy outcomes. So here's just a figure to show this to you. So we randomized about 10,000 women in each arm. And as I described, they would get either HPV or cytology. And then depending if they were negative, they would come back in either 4 or 2 years. If they were positive, there was quite a detailed what we call triage flow through, where they would get followed up depending on what their results were and their triage results were. So what did we find? We found that the summary is that if you received HPV testing, you were significantly less likely 48 months later to have precancerous lesions. So let's just walk through those numbers. So again, if you're assigned to HPV versus cytology, and then we followed you 48 months later, at 48 months, there was significantly less CIN3 and 2 detected in the HPV arm compared to the cytology arm. You can see the risk ratios here, 0.42 for CIN3, that most serious of precancer lesion. But for CIN2, our risk ratio was about 0.47. So, you know, a substantial reduction in precancerous lesions. And here, just I'll show it to you visually. I find this sometimes helpful. You can see here, these are the precancerous lesions detected at round 1. So the screening is better, it detects it earlier, and then you see substantial reduction. Whereas in the intervention arm, we didn't see that. Sorry, in the cytology arm, we didn't see that. Okay, and then the other thing just to know is as a screening tool, we also very keen to make sure when people are negative, they are really negative, right? We really want to ensure that the false negative rate is very low, because we send people back out into the world with reassurances that they don't have whatever the condition we screen for. And you can see here that HPV performs very well. HPV testing performs very well in this situation as well. So in the arm where women were assigned to HPV versus cytology, if you had a negative HPV, your risk ratio, your risk for CIN3 was substantially lower than if you had a negative PAP. Why is that? It's because the HPV has so much of a higher sensitivity that we had the negatives were absolutely certain to not have CIN23. So you can see the risk ratio for CIN3 at 48 months was 0.25 compared, and you can see similarly for CIN2 was 0.36. So really great performance characteristics for a screening tool and screening program. So what did we show? We showed that the primary HPV screening led to statistically significant increase in the detection of CIN3 at that first round. What did that mean? Subsequently, they had a much reduced rate at 48 months. We did see higher rates of colposcopy, but we also didn't see any psychological effects on primary HPV screening, which has been a concern. So where are we at with primary HPV screening across the country? You can see the big players are British Columbia, Ontario, and Quebec are in the process of preparing to move to HPV testing. There we go there. So just a reminder that it is what is critical about any type of screening is you need to have the follow-up. So it is not helpful to do a screen and not have a plan for follow-up. So with HPV, as you know, the plan, you need to go for colposcopy. So that's a procedure where done by a gynecologist where you actually look at the cervix and take a biopsy and potentially even treat. So this is the cascade. And so we're actually monitoring very closely and ensure that we set this up. We are continuing with our focal monitoring. We are looking at the protection of a HPV test at 120 months, so 10 years after. We're looking at the impact of co-testing, if there's any benefit to add cytology. And we're looking at the benefits of 2 negative HPVs instead of just 1. So one of the things we've been able to do so far is look at the impact of a single negative HPV. And what we found was that the risk for CIN2 detection remains very low for women who've had a single negative HPV. So back to that whole baseline negative and the value of screening, even after 10 years. And then where are the rest of the world on this? So Australia has introduced HPV screening. Italy has primary HPV screening with cytology triage in some different regions. And the Netherlands has introduced it. They had a more ambitious plan where they actually went to every 10 years for women 40 to 60. So that's an interesting approach. And I think they're having to revisit around the 40 to 49 because I think that was too long of an interval. What else? I'm just looking at the time here. What else is on the docket? Self-collection. So we're very excited in BC to be leading a very large self-collection trial where we are actually sending cervical screening kits to women who have never been screened or are very overdue for screening, and looking at the uptake, the acceptance, what is their experience, do they go through for follow-up. We also have a web-based approach where women can go online and request their own cervical kit as well. I also do work in low and middle income settings, going right back to that first map that I showed you, where you can see that we are looking at how to make self-collection acceptable in low and middle income settings where there's the highest burden of disease. So we've done work with rural women to understand their preferences and whether self-collection could work. And you can see here some of the facilitators and some of the barriers for self-collection. Right now, we are reporting out on the Aspire trial, which we ran in Uganda for women between ages of 25 to 49 who were eligible for screening. What we did was randomize women either to door-to-door recruitment with a village health team. They would get education and then a self-collection at home. And then we would take it to Health Center 4 where it was tested. And then when we got the results, the village health team would go back and give the woman results. And if there was a need, she would get follow-up for her HPV positive results. We compared that to a community mobilization arm where we actually had group health education meetings and would educate the community about HPV, and then women would go into a private tent and self-collect. And then the similar process, sample was examined at the Healthcare Center 4, and then they would return and we would give results. This is the village health team, and this is in my Uge district in Uganda. And yeah, and we are just completing that study. So I'm going to end there and hopefully have some time for questions.
Okay, thank you so much. There's so many different things. I think for me, one of the questions that I had was, and I don't know if you know the answer, the impact of COVID, because it is 2 shots. What potentially can be that, they didn't go back to school. They weren't, if they were supposed to get, public health, what happened? I don't know.
Yeah, so I don't, I'm just trying to see if I can pull up the slide for you, because we did, and I think everyone saw a reduction. So I'll just do a quick screen share. And this is your own Ontario data. So let me just show you this and screen share here. So you can see there what happened to the volume. So you had almost a 92% reduction, okay, compared to 2019. So that is problematic. And I know in BC, we saw a similar collapse of volumes, and still a bit of a hesitancy and reticence of practitioners to have women back in the clinic. What we've been doing, the BC Cancer Agency has been sending out invites and really encouraging people to go in. There's also a lot of interest in self-collection because of that.
Yeah, I can imagine. Well, yeah. And we do have a question.
Yes. So I didn't, great question. So I didn't want to get into it too much to confuse. It's not a lot of, I could talk on any one of those slides for an hour, as you can imagine. So I just had to be very superficial. So I'm actually on the Bill and Melinda Gates PATH single dose consortium. So what the question is about is, what do I know about the single dose? So there is move globally to look at the safety and effectiveness of one dose of the HPV vaccine. So there have been a couple of trials that have read out, the Kenshi trial, that's in Kenya, the DOORS trial, that's in Tanzania. We've got the Costa Rica trial, and they've looked at the immunogenicity and also tried to do some bridging for the impact of one dose of HPV vaccine. There remain, the preliminary data is strong that one dose offers, you get a good immune response. These were primarily younger folks, 9 to sort of 12, again, that same age. The issue, I think, concern that folks have brought forward is that of durability, so that duration of protection. However, I believe SAGE and I believe the, so in the UK, JCVI, and even I think the WHO is definitely looking at one dose. There's a couple of reasons I think they are looking at it. One is to, with COVID, the already fragile immunization system collapsed even further. So I think there's a hope with one dose just to try to cover a whole bunch of people. I think there's also the idea if you get one dose into 9 to 13-year-olds, you can, if we get information that says they need a second dose, you can still get them on when they're in school. So yeah, that is an exciting area that I think, holds promise, I think.
Mm-hmm. Yeah, our one's always better than 2 or 3. I don't know, with COVID, it's God knows how many doses we're going to get. But, I just had a quick question, and I just don't know. You were comparing HPV testing to sampling. Is the testing a blood test? How is that done?
Okay, yeah, sorry. So HPV testing is done very similar to a pap smear. So let me preface that. So a pap smear, you actually need to see the cervix, and you're actually taking a sample of a certain tissue, certain zone, region, the transformation zone where you have the transition from the squamous epithelium of the vagina to the columnar epithelium of the uterus. And so that transition zone happens at the cervix and then moves up into the uterus as women get older. So for a proper pap smear, you actually have to take a sample of that. So it's just a scraping, but you have to visualize it so you know where you're aiming. HPV is a test for a viral infection. So, and it's done through a molecular PCR molecular amplification technique, signal amplification, or sort of straight up PCR, so whatever it is. But so you only actually need for HPV a vaginal sample. So you need a sample of vaginal secretions. You don't actually have to get it from the cervix. So that's why self-collection can work, because women can insert and take the specimen themselves. You don't have to see the the cervix. So that's why we're super excited about the options for women. Undergoing a pelvic examination for many women is not something they want to do. variety of trauma, just
Yeah.
takes too long, personal space, whatever. So there's a huge opportunity to improve coverage with self-collection. So
Yeah. Well, I can imagine. And the other issue as well is just the fact, just the healthcare system is so strained right now. We're kind of catching up. Like, let's not talk about the number of cancers that have not been diagnosed over the pandemic. But yeah, it's if we can eliminate a little bit or move a little bit away from that primary care thing, and you can just do it yourself, that would be fantastic.
yeah, and I think so. You know, while I agree with you, Ruth, on that, I think we're very careful that women don't feel we're moving to self-collection for them to avoid the health system.
Mhm.
Like I think it's really important that folks know that it is actually as accurate, and it makes sense, right? Like if you're getting a vaginal sample, I'm just as good at getting a vaginal sample myself than my practitioner. It's not a complicated thing to do, because it's a molecular assay and they're trying to detect, the virus. As long as you have a good sample, it doesn't have to be from any one spot in the vagina. What I will say though is there is no point in doing HPV testing if women don't have access to colposcopy and the follow-up, because all you've done then is say, hey, you're HPV positive. Oh my God, well, what do I do with that? The reason we're doing this test is so we can identify precancerous lesions, and most importantly, so we can treat them. So I'm careful in my language to not, because as you all know, when you order a test, there's a chance it's going to be positive. Mm-hmm. Like the one way to not have to follow up on a test is to not order it. So I'm very clear. I also think it's really important that we are clear that we're doing this test to identify precancerous lesions. So there is a possibility that you're going to have to come in for a colposcopy, which is a pelvic examination where you undergo potential treatment, where you undergo, biopsy. So I think it's important our message be kind of nuanced on that.
Yeah, and often this is done with other tests at the same time, like a wellness check and things like that. Those things haven't happened either. But
they have not happened either. Correct. Correct.
Well, hopefully we'll get it all straightened out eventually, and that would be lovely. I don't see any more questions coming in, and so I'll give some people a little bit of time to enjoy their evening. And I really appreciate this, Dr. Ogilvie. It's sort of kicked off the whole campaign of, bringing this issue to pharmacists, and we're going to be talking to some other people about it, and maybe digging a little deeper into why don't they get the vaccine? What are parents? Are they worried? Why are they worried about? Well, misinformation, and pharmacists have been a very reliable source, and actually been asked many times for about the COVID vaccine. So we just need to know the script. We need to understand, kind of, and be aware that, people are going to get concerned about that when they find out about their child.
Yeah, and what I'll say is I've worked in sexual health and STIs for the longest time. And the one way to make sure parents are anxious and concerned about sexual health issues is for you to be anxious and concerned. So if you convey that we know this vaccine has no impact on sexual health choices, in fact, the data, I wouldn't want to ever say, give them the HPV vaccine, they'll make better sexual health choices. There's a part of me that wants to say that, but I won't say that. But I think it's really important to say there's data that shows there's no change. If you're awkward about that conversation, parents are awkward. Right. If you're comfortable, factual, straightforward, then parents read off that energy and go, oh, okay, this is something I can talk to you about. So I would really encourage that sort of approach.
Yeah, there's lots of it's a big issue, and it's it doesn't have a perfect solution, but anything we can do to kind of move things along. We can in Ontario inject the HPV vaccine, but it's not publicly funded when we do that. So right. So that's always the challenge for us. Yep. We are working at OPA to try to get that to happen, whatever we can do to help, because why not?
That is also to be honest, so in BC, if it's after if you're outside of school age, you also have to pay for it yourself.
Yeah. So issues there. A lot of that, I think, it's covered by private insurance. It could be covered by private insurance too. So there are avenues, but anyway, thank you very much for coming. Thank you everyone for attending, and have a great evening. So thank you so much. Bye-bye.
Thanks, Ruth.